Bonjour, good morning everybody. Thank you very much for being here, and thank you to our organizers and to our hosts for allowing me to join you today. I'm very happy to be talking to you about healthcare quality from a more global perspective. I was asked to say a few words about what's happening internationally in the context of healthcare quality. It's something that I think many of us are vaguely aware of, but it's been a very interesting journey over the past 20 years, learning how differences in translation can ultimately impact how successful we are. When we talk about global healthcare, I think one of the challenges that we face is that everyone has something else, something different in their minds. On the one hand, if you look to the left, and I apologize if it's small for the folks in back, healthcare can imply just rudimentary care in a place with a pounded dirt floor, maybe a bucket of river water, right? That facility might very well be labeled hospital. In the same township, if you go to the other side of town, there might be an Aga Khan facility with polished marble everything and cutting-edge IV pumps, and also called hospital. I think one of the challenges that we face as a global community is navigating a path forward for such a very different range of care settings. To the left, what you see is a lot more like what we would think of as an intensive care unit. That's actually in Vietnam during the SARS outbreak. But I share these things with you because the solutions that we bring to one place are very different from the solutions that we bring to the other. One of the things that I think we as a world community need to be focusing on is matching capacity to the type of care being provided. One of the things that I see in many locations is healthcare systems, facilities, and personnel attempting to basically apply what we take for granted here and in many parts of the well-resourced world directly to an infrastructure that's very, very different. When we look back, just going back to that picture, I think it's safe to say that on the extreme resource limited side of the picture, what we're trying to do is extremely basic, right? You would not try to do advanced medical care in a situation like that. That's actually the easy part of the discussion. It's really about what we're not going to attempt to do. On the right-hand side, though, when we start to be in places that look familiar, that look like an intensive care unit, there's a tremendous temptation to do more. But I think it's extremely important to think about what's underneath our health systems. What are the safety nets that we take for granted that might not be there? I'll say more about that in a moment. One of the approaches that we've been working on is to help map a stepwise improvement in capacity. So when we're talking about the basics, really it's shelter, light, a safe environment just for patients to be in. Beyond that, we want to think about sanitation, protective equipment, perhaps disinfection. And then at the third level, we're looking at microbiology capacity, reliable infrastructure like water and electricity. When we map it that way, we start to see that if all you're doing is providing first aid, your infrastructure is really a notebook perhaps for record keeping and a place to store your materials safely. If you're doing labor and delivery, you probably need a little bit more than that, some protective equipment, a way to manage placentas. But then when you start doing intentional elective surgeries, when you start to deal with complex trauma, and then lastly, when you start doing things like intensive care or dialysis, you really do need the reliable infrastructure that we take for granted. I'll say a couple more things about infrastructure before I move on, and these are parts of those invisible factors that, when they're missing, can have a profound negative effect. We take for granted medical records, right? But in many parts of the world, a medical record is a small folded piece of paper that people carry with them on behalf of their children. And when you ask for a record, it comes out of the bottom of a bag and gets unfolded, and you look at this faded pen writing, trying to make sense of what was going on with this patient. Medical records that we all rely on to do surveillance, to understand quality, that is an integral part of a safe healthcare system. Another piece that I think people forget about is the value of professional nursing. We learned very vividly with MERS in South Korea how valuable it is to have professional nurses taking care of all of the ADLs, the activities of daily living, for patients. When you're relying on family members to come in and bathe, feed, and otherwise deliver care, the ability to provide consistent infection control, to maintain hygiene, becomes very, very different. And if those family members are then cross-pollinating, the spread of a respiratory virus like MERS becomes very, very rapid. I'll say one more thing about capacity, and that's limited versus lost. One thing that we see very consistently is that if there's inherently limited capacity, most people have figured out ways to do the best they can with what they have. And helping that situation by adding more resources, by innovating, is a fairly straightforward task. Much more complex, however, is lost capacity. So there are countries around the world where there used to be a robust governmental support for a healthcare system. Think about the former Soviet Union, where money, resources, supplies were provided. When that started to fade, there were facilities left without replacement filters for their negative pressure isolation. TB sanatoria that haven't had reliable supplies of medications for a very long time. Those are places where the loss of infrastructure does not routinely mean people pull back on what they're trying to do. Right? People continue to try to do the types of care that they were doing when they had ample resources. I bring this up because many of you, I imagine, will be in situations where you can provide consultative input, where you can provide that professional insight to places that need assistance. But I will caution us that when you're dealing with a loss of infrastructure, when you're looking at an erosion of capacity, the conversation becomes very, very different. You can imagine that people are not happy about a loss of infrastructure, and there's a tendency to be driven by a desire to maintain what people had. So these are a few examples of the tiers of care that we envision. This is something that we've worked with the World Health Organization, OMS, through the years to try and codify. One of the reasons for this is that we need strong allies in ministries of health to ask for the right thing. One of the most unfortunate moments in my international career has been hearing from a minister of health who was offered resources by an international organization to build a dialysis unit. This is a city where the main hospital had running water 2 or 3 days a week, electricity that came on maybe for a couple of hours a day. There was no laboratory infrastructure, and yet they were going to build a dialysis center. And she said yes, because why would you say no to a lovely new thing? But had she been able to guide that conversation to say, look, dialysis is great, we've got maybe a couple of renal failure patients, but what we really need is to have safe labor and delivery because there are babies being born every day. Can we maybe negotiate something different? The value in having what is comparatively dry as documents go, but a WHO schema for how to make these investments is that we can then start to systematize how we ask for resources. What we would like to see is the investments that go along with things like advanced technologies. What you see here are some autoclaves from Angola, where back in the day they had a fairly robust infrastructure. Unfortunately, with importation of technology, what we see over and over again is an absence of the support that goes with it. I can't tell you how many times I've seen laboratory diagnostic equipment that didn't have the right fuses in sub-Saharan Africa and therefore hasn't worked in 10 years. And that's despite a really shiny sign on the sides that says, donated by such and such organization. Having the translation actually match the type of care that you're providing is key. An element that we see that is rampant internationally is injection therapy that is overused. What you're seeing here are the number of injections per year, and across the bottom, it goes from 0 to 12 injections. And in some parts of the country, people are having nearly a dozen injections a year. This is for routine care. If you think about the number of injections you've received over the past year, that starts to paint kind of a notable picture. If you look at the red bars and see that many of those injections are being provided by reused equipment, this becomes alarming indeed. The picture on the upper right-hand corner is a tub of disinfectant in which injection equipment gets dropped after it's used. This is not at a health clinic, it's at a barber shop in Cairo, where health injections are provided on a routine basis. Because of that, Egypt has had a very high rate of hepatitis, and tackling this is something that requires a great deal of social engineering so that people request not an injection. People don't expect to be injected in order to get better. Another hidden issue, unfortunately not truly hidden, is waste management. What you're seeing here is it's actually a play yard for the children of the nursing staff in a hospital in South Asia. These are mountains of medical waste. And this picture is replicated all around the world where people are able to acquire disposable equipment, but there's no place to put them. And this is where the bigger picture infrastructure that I want to share with you comes into play. Medical waste is largely plastic, often highly contaminated. Here, if you walk up closely, you'll see the little red dots. Those are sharps containers that are full of bloody needles and whatnot. If you were there 5 minutes before I took the picture, there were 4 or 5 children running around playing, pulling material out, dragging it around and swinging it. This is something that I would very much like to see change, to the extent that we're talking with organizations like the African Union about saying, well, what if donors who drop off multi-ton shipments of injection equipment have to sign something that says they will remove a similar quantity of waste when it's done? How about that kind of donation, right? Thinking through this also, though, identifies other weaknesses in the fabric. So when you're talking about getting rid of medical waste or waste of any sort, there are a couple of things that happen. One, people try to burn it. And I've seen great examples of beautiful incineration facilities donated by the German government that are in a purpose-built building, highly efficient, eco-friendly. All of that is great, but if the fuel doesn't arrive because the roads are washed out, then suddenly you don't actually have an incinerator. What I saw that was most striking is that, as any normal person would do, if you go to the incinerator and there's no fuel, you might just leave the bag of garbage by the incinerator thinking, oh, when the fuel comes, I'll come back and burn this. But if the fuel doesn't come for many days and the waste keeps coming, then pretty soon you actually can't reach the incinerator anymore, right? There is a wall of garbage. It got so bad that, in fact, the garbage started blocking the external door of the building, so that when the fuel finally arrived, no one could get to the incinerator to begin using it again. And so they basically walked away with a mountain of garbage. That speaks to the absolute need for infrastructure like roads and fuel to support healthcare. It's not just delivering syringes, it's not just delivering medications. That easy solution continues to harm people around the world. Another hidden issue that I don't think people talk about is crowding. It is absolutely adorable to see a great big table full of babies. I can't think of anything cuter unless you added some puppies maybe. But even though this is cute, from an infection prevention perspective, it gives me the shivers, right? Those babies are essentially now one microbiologic organism. There is no way to prevent the spread of infection from one to the next. 3 little tiny low birth weight babies in a single plexiglass box. This is unfortunately the reality around the world in many, many locations. And reducing that crowding is something that is essential, right? Here's something less cute. These are adult men head to foot in a single twin cot. One of them has an IV in, the other one has an NG tube. Below you see several people in a single bed as well. This is not acceptable, right? On the other hand, when you talk to the healthcare facility, if patients have come walking for 2 days to seek care, you're not going to tell them to walk home. You're going to let them in. It's the moral thing to do. And so in many facilities, whoever is most likely to survive gets the top of the bed, and as things look more and more grim, people are placed under the bed. I mean, this is a real thing that happens. Well, what's the problem here then? Why is there crowding? This is a network-wide, country-level issue where decisions need to be made about how do we stem the flow of patients, how do we divert the ones who shouldn't be there, how do we right-size a healthcare system. So I bring this to your attention because as infection preventionists, we see this and we feel like, okay, we have to fix this. What are we going to do? And some of the solution isn't just us. I push back firmly against the idea that by applying infection control, a magic spray, we can take an unacceptable situation like this and somehow make it okay. I bring this to your attention because I want all of us to feel confident and comfortable saying, no, this is not okay. We will deal with it in the interim, right? We will take care of patients no matter what, but it's not okay, and you can't keep doing this and just say that we need more infection control. That is a guaranteed ongoing failure. So what are we doing? We're focusing on healthcare facilities, and we're making use of the attention that's being garnered by outbreaks. One of the reasons for that is over and over again what we see is a pattern where infections come into a community, patients go to a healthcare facility, and then because of cross-transmission, there's a burst. This is the pattern of Ebola through the years, right? Somebody crosses the jungle, maybe has contact with an infectious bat or something else. They might come back to their communities and there might be spread within their family. But it's generally not until someone gets to a healthcare facility where trainees, nurses, students, doctors suddenly become a notable epidemic that leads to WHO being notified, other health agencies being brought in. That same pattern is what we saw with the SARS outbreak in 2003. So those of you who recall, Hotel M in Hong Kong in the middle there was the original identified source, but all of the marginal transmission through multiple countries happened by amplification in healthcare. And if you mirror that and do the multiplication with all of the travel that's occurring on a routine basis today, this is a heat map of how people travel commercially. You can imagine that the ability of healthcare facilities to create global epidemics is extremely robust. The good thing about outbreak type responses is that they're very visible, they make great attention-getting copy, and you can bring people to the table. This is something that we take advantage of and try to do the most we can with, but the problem is the residual effect is always very limited. I can't tell you how many times after spending months in remote locations around the world, bringing in kiloton quantities of infection control material, protective equipment, etc., endless training, lots of reinforcement of hygienic infrastructure. You come back a few months later and there might be one leftover gumboot, right? And maybe 1 or 2 gowns, and that's it, not a stitch left. The problem with that is that for the people working there and living there, they're not blind to this. They realize that they were just taught you're supposed to do it this way, and then all of that vanishes and you're left to make do with what you got again. That is demoralizing to the extreme, and again, not a pattern that we need to perpetuate. In fact, I think, again, as a field, we need to be vocal in helping people say, that's not okay, right? If there's a right way, then we all want to be able to do it. If we can't do it right, maybe we shouldn't be doing it all. The establishment of new capacities is what we're driving towards internationally. We want an ongoing effect. We want regional resources. We might not be able to lift every single facility, but every single region should have the resources and personnel with the appropriate training and leadership to establish safe healthcare. Retaining the capacity is another key element. One thing that those of you who have worked in international settings recognize is that good people get snatched very quickly. If you are a capable, hardworking infection preventionist in a remote sub-Saharan location, I can tell you there are 50 NGOs just clamoring to hire you and bring you aboard, which then removes the capacity from the healthcare system. So retention of capacity is an ongoing challenge, but it's something that needs to be engineered. Ms. Cole mentioned the global threat of AMR. This is something that we are using to drive infection control investment internationally. The scope of what could be, this is a chart that shows the probable deaths by 2050, and we're talking upwards of 10 million from Asia and Africa alone in just 1 year. The potential impact of untreatable infections is vast. That said, we're able to then channel national investments and international investments by focusing on this problem, which, as you well know, ties very closely to every component of infection control, right? Whether it's hygiene, environmental services, data, surveillance, protective equipment use, training, and so on. So as we look at this in the US nationally, we are focusing on national policies. We're improving detection capability, at least in a regional level, through laboratory testing. We are following trends and identifying emerging challenges in AMR, and building workforce and capacity so that we can actually contain emerging resistant organisms. The advocacy that we're able to do because of the national program has been extremely helpful. We've worked with a variety of countries to establish national plans and policies, and this is where we're able to insert language that says, in order to be considered a full-fledged acute care hospital, you must have running water. You just do, right? That is necessary. You need to have reliable electricity. You need to have medical records. You need to staff nursing in an appropriate way. It can't be just one matron with no one to help her, managing dozens and dozens of patients. Strengthening the laboratory infrastructure. If you can't make a specific diagnosis, how do you do surveillance, right? From a syndromic level, it's very difficult to have directed and effective interventions. And so lab strengthening is another component of this. I'll show you some examples of how we do that in a moment. One other thing to think about in terms of lab strengthening is lab utilization. We have worked, for example, with the country of Georgia, an excellent infrastructure, but no one uses laboratories because they've recognized through the years that their microbiology infrastructure was not altogether reliable. So then clinicians aren't going to bother sending a specimen, and when the national government says, well, we want to do laboratory-based surveillance for antibiotic resistance, we can help build the lab, but if no one's sending specimens, then you have an ineffective system. So there's the testing capability, but then there's also going back and training healthcare providers to say, this is how you use a laboratory, this is how it can help your patients. National surveillance systems are very much sought after in many locations, and this is something that I think helps bring data to the ministry level that can then drive investments. The workforce strengthening that I mentioned is key to everything that we do. We need partners on the ground who understand IPC. And then as a small asterisk, the ability to respond to outbreaks is always something that is of value. So plans and policies are something that we're doing. We work very closely with our microbiology societies to invest in local laboratory capability and do on-site training. We also fund a large number of research and development groups to look for the next game-changing solution. So if you think about what it means to run a laboratory in terms of quality assurance, refrigeration, all of the maintenance that goes into it, it's not an easy lift. Think about what it would be like to try and create telephone poles and telephone wires across sub-Saharan Africa. It would never happen. But we have communication there now because of the Nokia cell phone. Remember the big chunky Nokia? Very, very robust, affordable, and it was a complete game changer. All of a sudden, we didn't have to wait for a massive outbreak in a remote location. We could get a phone call that said something seems to be happening in this village, right? A wonderful change in how things are happening. Well, what is the laboratory equivalent of that? We're increasingly relying on smartphones. The number of places that have a smartphone with satellite connection and no running water is actually kind of ridiculous. But it is an opportunity. And if diagnostics can be held in your hand in a way that brings that to the patient's bedside, that may be something that we see happening soon. Also, from a remote perspective, is remote training and consultation. The ecosystem is something that was piloted in the Four Corners region of the Southwest United States, where in very remote rural locations we're able to deliver diagnostics and consultation. We're now doing this internationally so that we can provide expert input and advice without actually having people be on the ground. I mentioned surveillance systems. This is something that we work very closely with WHO on. But also with device manufacturers. If the electronic systems that are being purchased in many middle-income locations can facilitate effective surveillance, that once again drives ministerial understanding and investments in the infrastructure that we need. The ministerial component of this is, from my perspective, the most crucial element to actually move the needle in a permanent way. We can all keep helping in crazy situations where there's overcrowding, lack of infrastructure, an absence of nursing, no data. We can keep going, but that's not going to change the reality in many locations. The investments that we're making right now are very much focused on training young people at ministries of health, making sure that the ministerial leadership understand what we're trying to achieve, sharing that idea of what is unacceptable, right? So that when we're talking with donor organizations, when we're talking about investments, they start to make more sense from a sustainability perspective. These are all the elements that we see having to then ultimately translate to national priorities. You need the infrastructure. You need the resources and maintenance. Personnel need to be trained and retained and paid. And all of this has to be a shift from crisis response to capacity building, because that ends up being the key to sustainability. For everything we're trying to accomplish in all of these locations, whether it's going from bare bones pounded dirt floor to something a little bit better, or going from what looks like a reasonable intensive care unit, but adding disinfection, sterilization, device tracking, other hygienic safety nets. All of these things have to be sustainable. A short-term infection control solution is not an infection control solution, right? It's a false sense of security. So with that, I'm going to be respectful of our time, and thank you for your kind attention, and a quick nod to our team from the field. Thank you so much.